right, let's conclude with gram-positive regular non-spore forming bacilli. So remember that regular refers to the fact that it's going to stain uniformly and it doesn't assume pleomorphic shapes. Well, what does that mean? In other words, it means that when you do the gram stain, a regular would stain correctly. You would make your heat fix, you would do your smear, heat fix, stain, and it would stain uniformly. And then not having pleomorphic shapes means, they come in traditional classic characteristic shapes that we're used to. Pleomorphic meaning that they can take different shapes. So basically what we're going to do is we want to study the ones that do not stain regularly or have pleomorphic shapes and or both. So who are the two major medically important ones? This is Listeria monocytogenes, and please forgive me on this next one, but Eryspelothrix russopathae. And bless my heart, I can't say that 3 times fast. I can hardly say it 1 time. But anyway, let's talk about Listeria. Okay, Listeria is a non-spore forming gram-positive. Okay, we've got that. And it can range from cocobacillus to long filaments, which means cocobacillus means that it's a bacilli, but it's kind of fat and stumpy, short. It's kind of plump. And then, of course, you get long filament would mean that they're long. So they can range in size. They don't just take one characteristic size. They do have flagella, but they don't have capsules. The problem with Listeria is that it is resistant to cold, it's resistant to heat, it's resistant to salt, it's resistant to pH extremes, and it's resistant to bile. Oh my goodness, right? It's resistant to all of these things that would normally keep bacterial growth in check. And we think that the virulence that Listeria has, is attributed to its ability to replicate in the cytoplasm of the cell after inducing phagocytosis. So what happens is that it gets into the cell, into the cytoplasm of the cell, therefore it does not alert the humoral immune system that we studied in previous unit. Okay, so basically what happens is that the microbe gets phagocytized by the cell, and then, then it does its replication process, and then it stays encapsulated. Therefore, your immune response doesn't recognize it as being there. What is the epidemiology and pathology or pathogenesis of listeriosis, which is the condition of Listeria? We find Listeria in soil, water, and animal intestines, and it can contaminate food, and it can grow even during refrigeration. Remember, refrigeration typically will slow down the growth process. Well, with Listeria, it can still grow and flourish even though it isn't under refrigeration. So we typically think of listeriosis as associated with dairy products, poultry, and meat. Most of the time, probably all of us have probably been exposed to Listeria at some time or another, but we just maybe get a little mild gastrointestinal distress, but nothing major. The problem comes in with immunocompromised patients, fetuses, neonates, because it can affect brain and meninges. As a matter of fact, there's a 20% death rate associated with Listeria. So when we think of how to control it, we typically, there's these tests that we can do. It's called ELISA, and it's immunofluorescence, DNA analysis. Typically, you want to give the patient ampicillin. But the key is to what? Pasteurize and make sure that your dairy and your fruit juices and meats and things like that have either been pasteurized or cooked. So, I'm sorry, go back. So, typically, you hear about this when you hear of ladies that are pregnant being asked not to eat soft cheeses or unpasteurized milk or unpasteurized fruit juices or deli meats that have not been heated up or cooked. This is typically what you're worried about. So it's Listeria is typically the one that they're targeting when they talk to your pregnant females about not eating certain foods. This is typically the bug that we're thinking about. Okay. Woo! Erythropelothrix russopathae. These are gram-positive rods. They're found in animals and in the environment. Now, this is weird. The primary reservoir is the tonsils of healthy pigs. They enter through skin abrasions. They multiply to produce these erythroid or dark red lesions. Typically what will happen is that you want to make sure that when you're getting your pork, they have been vaccinated, or not vaccinated, but given antibiotics of penicillin or erythromycin. There is a vaccine that pigs are given. Humans are the greatest risk. The greatest risk are those that actually handle carcasses or meats or deal with animals, specifically pigs. So this would be things like slaughterhouse workers, butchers, veterinarians, farmers, fishermen. This would be who would be most concerned with contracting this particular microbe. Okay, so it's just kind of showing the redness around the joints and in the hands. Okay, so now we want to talk about, as we wrap this up, gram-positive irregular non-spore forming bacilla. So again, irregular means pleomorphic. They're going to stain unevenly. And so who are the gram-positives that we're going to be thinking about that fall into this category? So it's going to be your Corynebacterium, your Propoionobacterium, your Mycobacterium, your Actinomyces, and your Nocardia. So let's start with Corynebacterium. Corynebacterium diphtheriae. Straight or somewhat curved rods that taper at the end, but they can have all kinds of variations or pleomorphic variations. Typically, the reservoir of a healthy carrier is a potential for diphtheria is always present because of this. Most cases involve non-immunized children that live in unsanitary conditions and conditions that are very crowded. It can be acquired via respiratory droplets, okay, so from infected individuals or carriers. So Corynebacterium diphtheriae, this is what it would look like stained. Notice the tapered tails, the irregular shapes. They don't have any one particular shape. The two stages of disease, you have the local infection, right, which is the infection by the Corynebacterium diphtheriae. It's going to cause an upper respiratory tract inflammation. This is called the primary infection. The patient is going to have sore throat, nausea, vomiting, swollen lymph nodes. But the key thing for this is you're going to find this pseudomembrane that forms at the back of the throat. And this can actually cause asphyxiation. Or depriving them of oxygen. And then cutaneous diphtheria is the secondary infection. Now, we also know that Corynebacterium diphtheriae will release a toxin known as diphtheria toxin, which can lead to toxemia, and typically the target organs for this are going to be the heart and the nerves. Okay, so on the left you see cutaneous diphtheria, and then on the right you see that pseudomembrane that forms across the back of the throat, and of course this can lead to asphyxiation because they can't breathe. How do you prevent it? Or treat it? Well, there is a toxoid vaccine series that's given. Okay, so the DTaP, diphtheria, tetanus, and pertussis, and you get boosters. They do treat it with penicillin and erythromycin. And there is an antitoxin that can also be given. All right, next one, genus Propoionobacterium. So like Corynebacterium in morphology and arrangement, it differs by being aerotolerant or anaerobic. Okay, so this is typically the one we think of here is Propoionobacterium acnes. So acne is common in your pilosebaceous glands of the human skin. This is the causative microbe for most acne. We all experience that probably growing up. It is occasionally involved with infections of the eye and artificial joints. All right, so infections by Corynebacterium diphtheriae cause a pseudomembrane and a respiratory distress that can be prevented with a vaccine. Is that true or false? And hopefully you said true. Remember DTaP, the diphtheria, tetanus, and pertussis vaccine can prevent this. Okay, mycobacteria, acid-fast bacilli. So mycobacteria is a gram-positive irregular bacillus. It is acid-fast staining, and if you'll recall, that means that mycolic acid is present, which is kind of a lipid base. And remember, oil and water don't mix, so when they stain, they're gonna have an irregular stain as well. They are strict aerobes, which means they've got to have oxygen. They produce catalase. Okay, so they produce catalase. They do not form capsules. They do not have flagellas or spores, and they grow very slowly. So that is an example of your mycobacteria. So who is the disease, or what's the disease associated with it? Well, tuberculosis. Okay, Mycobacterium tuberculosis. Tubercle bacillus are long, thin rods that grow in the sinus masses or strands called cords. They don't produce exotoxins or enzymes that contribute to their infectiveness. Infectiousness. Their virulence factors are, again, that wax, that mycolic acid that I mentioned earlier, and basically they're not destroyed by lysosomes or macrophages like other bacteria are. This kind of shows you a picture of what it looks like growing on an agar plate, and to the right it kind of shows you the cords that form from this bacterium. How is tuberculosis transmitted, or who's involved? Well, things like inadequate nutrition, a debilitation of the immune system, poor access to medical care, lung damage, and genetics are some of the predisposing factors. It's estimated that a third of the world's population and 15 million people in the U.S. carry the tubercle bacillus. The highest rate in the U.S. occurs in recent immigration, or immigrants, not immigration, immigrants. So there's a lot of carriers for this. But just because you're a carrier doesn't mean you contract it. So bacillus is very resistant. It is transmitted via respiratory droplets. Now, of that, what was it? Let me go back. A third of the world's population, 15 million in the U.S., 5 to 10% are actually infected. Okay, so the number of infected is actually fairly low compared to how many carry it. Untreated, the disease progresses slowly. The majority of TB cases are isolated to the lungs, even though you can have extra, that they can occur in other places outside of the lungs. The three major types of or when you classify tuberculosis, you classify it as primary, secondary, or disseminated. And notice that secondary tuberculosis is reactivation or reinfection, and then disseminated is extrapulmonary, which means outside of the lung. All right, what is the infectious dose? Ready? 10 cells. Oh my goodness, okay? This is why we worry. Or not worry, but this is why we're concerned when you find out that somebody has tuberculosis if they have been around, like large numbers of people. Because it only takes 10 cells for an infectious dose. So remember that these are going to be phagocytized by the macrophages that are in your alveolus, in your lungs. After 3 to 4 weeks, the immune system attacks, forming tubercles. And basically, it's going to be the central core, which has the bacillus, and then surrounded by white blood cells. These are called tubercles. And if the center of the tubercles break down into necrotic caseous lesions, they begin to calcify. Now, why would that be problematic? Because your lungs need to expand and contract. So again, it kind of shows you the caseous necrosis. It shows the epithelial cells surrounding it, and basically it's a hardening. Okay, so if a patient does not recover from primary tuberculosis, reactivation of bacillus can occur. Tubercles will expand, will drain into the bronchial tubes in the upper respiratory tract. Gradually, the patient will experience more severe symptoms such as violent coughing, greenish or bloody sputum, fever, anorexia, fatigue, weight loss. And if left untreated, there is a 60% mortality rate. Okay, that is high. Okay, 60% mortality rate. So again, this is a nice little flow chart to try to show you if you're exposed and it's inhaled into the lungs, what path it can take, and whether you're TB positive or negative, or just basically gives you a nice flow chart. Extrapulmonary is just that, extra, outside of the lungs. So during the course of reactivated TB, bacilli disseminated can go to lymph nodes, kidneys, long bones, genital tract, brain, and meninges. And notice that if you have the extrapulmonary TB, the complications from these are grave. And again, it's because of that calcification of those tubercles and those caseous lesions. How do you detect TB? You do what is called a tuberculum sensitivity test, okay, Mantox test. And basically what's going to happen is that a local intradermal injection of the protein is given. And they look for a red wheal to form in 48 to 72 hours in duration. It's established a guideline on how large that wheal is as to whether or not you are a carrier or you've been exposed. In vitro TB test, there is a new method based on blood test. And of course these are, it's called the gold test and then the TB spot test. You can do chest x-rays. It's non-diagnostic, but it's used to rule out it's used to rule out pulmonary TB. You can then take a sample of the sputum. You could also do an acid-fast staining. Okay, and then those are very specialized forms of staining. And then the last one is that you can actually culture an isolation of the sputum sample and actually do biochemical test on it, and just like we're going to be doing the McConkey mannitol salt, blood agar, whatever, we can do all those biochemical tests to actually try to identify if it is actually tuberculosis. This is a test that if you're going into healthcare, you will be given. You're given the injection of the PPD, that protein, and then you allow it to go 48 hours. You have it retested or checked, and a small bleb is going to form. And if that bleb is less than 9 millimeters, you're considered category 1 positive. If it's if it's between 1 and 4, you're negative. Okay, if it's between 5 and 9, it's positive, you're category 1. If it's 10 to 14 millimeters, it's category 2. And if it is greater than 15 millimeters or greater, it's a category 3. If you pop positive, don't freak out, don't panic. They're then going to do x-rays to try to determine if you're just you've just been exposed or if you actually have tuberculosis. Here's what the x-rays would show if they see the caseous or calcified lesions. So how do you treat it? 6 to 24 months of at least 2 drugs. 6 to 24 months. This is going to be how you treat it. Many strains of tuberculosis are resistant to at least one of the drugs commonly used. Most common treatments begin with initial four drugs, and it gives the example of what the 4 drugs are. And then you have to take what's called a continuation phase, and then you would take these drugs for another 18 weeks. And again, it's a very intensive treatment process. So, concluding, tuberculosis is spread via contaminated fomites, food, respiratory droplets, or vectors. And hopefully you said respiratory droplets. All right, this concludes Chapter 19. Thank you very much.